Yes? Good evening. Welcome to Dr. Gore Show. I'm so pleased to have Dr. Kedar again back on our studio to talk about heart disease in women and evaluation. Welcome to Dr. Gore Show.
Thank you.
So, if you have missed our first show, Dr. Kedar Sankholkar did his training in SUNY upstate, and after his medical school, he came to Beth Israel to do his training in internal medicine, and he went on to do fellowship in cardiology at Westchester Medical Center. So in those few months that we haven't seen Dr. Kedar, he passed his cardiology boards, which is a very, very difficult board to pass. So congratulations. So now you are a board certified cardiologist.
Thank you.
So welcome back. And you know, as an OBGYN, I see patients in perimenopause, menopause, and not only earlier on, but at that point, I get really, have a long discussions about, why it's important to, control their cholesterol, why the sugars has to be controlled, and how their risk is changing as the estrogen level goes down. And a lot of times I find that even some of the cardiologists kind of don't emphasize to women about why it is important to get the lipid profile under control before menopause, so when the changes happen, it's a little bit easier to control. What are your thoughts about that?
Correct. I think you bring up a good point that prior to menopause, the hormone profile in women have a protective effect against cardiovascular disease, meaning you're less likely to have a heart attack when you're before menopause.
Okay.
As you start to get close to that time, which you mentioned is perimenopause, and afterwards, you start to lose that benefit against heart attacks. And if you have an abnormal amount of cholesterol, a high amount of cholesterol, or other risk factors like heart disease in your family, smoking, high blood pressure that's always been uncontrolled, now those things will have time to catch up.
Right.
And that protective effect you had from estrogens and progesterones will not be protecting you anymore.
Correct. So, cholesterol control is very important anyways. But also, the way the disease presents is slightly different in women than men. They sometimes don't have classical symptoms. They might feel like gas pains. They might feel a little bit bloated feeling. And those symptoms are slightly different in women than men. And most of the time, not only the patients, but physicians say, oh, maybe it's your gallbladder, maybe it's a gas. It's nothing so obvious sometimes that it's not like the crushing chest pain or radiating to the arm or back pain. Do you agree with those sentences? How do you counsel your patient? What symptoms a woman should look, which is slightly different than male presentation?
Absolutely. That's why women in heart disease is almost a separate subspecialty of cardiology at this time, because although in large part a lot of the symptoms you mentioned with the crushing substernal chest pain going down to left arm can happen in women, oftentimes there are other symptoms that come first before it becomes full-fledged chest pain. Sometimes it can just be feeling of burping. Sometimes it could just be nausea.
Right.
Sometimes it could be a little bit of a weird feeling here and you call it gas.
Right.
But I urge these women to take it seriously, don't put it off. And of course, women also usually show up 10 years later after men, after menopause.
Correct.
So there's a longer time that the cholesterol, the blood pressure has had to take effect. And as you get used to it, your symptoms are not full-blown.
Correct. And I think to elaborate on that point, a lot of times I've heard terms that most Indian use, which is not an English terminology, which is similar, is ghabraman. You feel like you can't breathe, you feel like something uneasiness, and that usually I tell them that's something to worry about when you feel, when you were not anxious and suddenly feel like, a sudden feeling of that, those symptoms. I think it's very important they know about it. So a woman has come to you for a routine checkup. She's in her 40s, maybe she's slightly obese, and has borderline cholesterol. What's your advice at that point to this person?
At that point, the most effective way to change that person's risk factor profile is to encourage what everybody knows: diet and exercise.
Correct.
Lowering saturated and trans fats in their foods, and losing weight. I believe I mentioned this in the previous episode,
Sure.
that losing weight, the most effective way is power walking. 15 minutes a day, twice a day, walk as fast as you can. You don't have to do anything extraordinary.
Right.
And that's
right.
what I would recommend.
Correct. Now, you did talk about, the cholesterol and losing weight and diet. Now, is there a difference in the type of cholesterol woman has, which is higher? About like triglycerides are different than the male, or when the cholesterol in the lipids, is there a difference between high levels of triglycerides in women than men, LDL and men and women? What's the observation?
The observation is that overall, women and men, in terms of their risk factor profiles with cholesterol, are very similar. However, the way they process it, whether they're younger or older, before menopause and after menopause, is what's different.
Correct. So, what about the lipoprotein particles? Are they large in women, or they do become small after menopause? Is there any studies about those lipoprotein particles? And
there have been some studies that are up and coming, but nothing right now has confirmed one way or another.
all right. So at this point, we don't have recommendation for the difference in the stuff. So we've told the person, yes, go on a diet. She's exercising. But sometimes it's familiar. She can bring it down to an X amount, but she can't make it to an ideal. Is there a way where it is a little bit different to manage as far as the medication goes in a woman or a man? What are your thoughts?
I think medications in women, if you're postmenopausal, let's say, I know you said a 40-year-old woman, but let's assume that it's a little older, the first line of therapy, assuming the diet and exercise have not met the goals, is statin, which is a lipid-lowering medicine. In Indian population specifically, I like to use rosuvastatin because amongst the entire family of statins, that one seems to have the least muscle pain in patients, which is a common side effect, especially in Indian patients. In terms of other sorts of therapy, such as hormone replacement therapy, in the cardiovascular and cardiac literature, that has been proven not to help against lowering heart disease and stroke risk.
Okay. So that will be your first line of treatment.
Correct, a statin.
Now, there are times that a lot of women are postponing pregnancy due to, career or the right kind of person they have to find. And sometimes I see these people who are already on statin medication and they need to get pregnant, and I can't give them statins when they are pregnant. What do you advise to this woman? What is a safe way, if there is any medication, or we just advise, say, control your diet, this 9-10 months, be off statins, and then we'll put you back on. How do you manage these patients?
Right. So, assuming that we're not talking about the rare cases of familial hyperlipidemia, the average woman who's got a adverse cholesterol profile and at risk, you have to remember that the risk we're talking about that we're treating with statins is over a lifetime. If you don't take a statin for the time of your pregnancy, you're not going to necessarily get a heart attack or a stroke at that time. And every moment you're balancing risk versus benefit of everything we do.
Absolutely.
So if there's potential harm to the mother or the fetus, you obviously want to put that as a priority. And then immediately after birth is given and it's safe and OBGYN says it's okay, we can restart the statin.
Correct. So I think that's been my policy as well, that yes, you're not going to go crazy. You're not going to start eating whatever you want. You're still going to eat a really decent diet while you're pregnant, but I'm going to avoid those medications while you're pregnant because there's definitely risk factors and increased risk of anomalies. Even we don't give it while breastfeeding. So after the breastfeeding is done, they go back, and there is a lot of mobilization of fat anyway happens during pregnancy. There's a lot, if you do anybody's cholesterol level before pregnancy, during pregnancy, you're going to get much higher reading during pregnancy because the fat is getting metabolized to supply to the baby. Right. So their levels anyway come abnormally high if they check during pregnancy. But if we control it afterwards, I think they are fine. Yes. So that's kind of a take-home message here, that don't worry, a few months you're going to stop it. This is a lifetime of risk. If you control it before pregnancy and after pregnancy and get it to an ideal level, during pregnancy you don't have to take medication, then we can just watch it with the diet. There are some exceptions to the rules, and let your physician decide about that. So we've kind of discussed a little bit about the heart disease in women, that it comes a little bit later, the presentation can be different, the medication and the... Now, is there a difference in the level which you want to optimize, different in male or a female, or what's the guidelines?
In terms of what?
The level of your lipid profile or your cholesterol level, are they same for women? And, you know, saying that the other risk factors, the family and age, everything is standardized. Is there a difference in the number that you want to achieve different?
Correct. As of right now, the American Heart Association, American College of Cardiology have not come up with actual hard numbers between a man and a woman to bring the cholesterol levels down. What's more important is the cardiologist or the internist should look at the entire picture of the patient. They should look at their risk factors, which is their age, whether they're a man or a woman, whether they had family members in their 30s versus their 80s who had heart attacks, whether they're smokers. All those things, putting it together, you have to make an informed decision about how tightly you need to bring the bad cholesterol levels down. And of course, just like I said with risk versus benefit, if I'm increasing the levels of the statin, but the patient's starting to get side effects that affect their life, affect their ability to exercise, then you have to back off on that also. So there might not be hard numbers anymore, but there's certainly a way to strategize about a risk factor profile and come up with a plan between the patient and the physician to lower the risk of heart attack or stroke in the future.
Correct. So, you know, we've talked about women and heart disease and how it is so important, because that's one thing women always neglect is their health. And if they get the cholesterol a little bit under control earlier on, hopefully we can delay it a little bit more further and take it from there. Of course, for South Asian, the levels have to be a little bit lower than the American standard, because we are more prone for getting heart disease. Now, the outcome as far as, say, if there's a surgical intervention or cardiac catheterization is required, is it same for female and male, or is there any other way that you'll manage differently? Like there's a 1 blockage to 3 blockage. Is there any way your management style will change? Depending upon just the sex of the person?
Yeah, so I'd like to talk about 2 different possibilities that a female patient can present with chest pain. If they have a chest pain and all the blood tests and EKGs show no heart attack, but there is a high suspicion that there is still a heart attack going on, if that woman were to get catheterized and we do the angiogram to look at the heart's arteries to see where the blockage is, oftentimes there is no blockage found. Whereas in a male presenting the same way, there is a blockage found.
So you think it's a spasm most of the time?
So there is a differential diagnosis, which I'll talk about in a moment. And then the other possibility is a female who's coming in with the same chest pain, but there are blood tests that can't come up abnormally or cardiac enzymes. The EKG is abnormal in that case. Just like a male, you would find a blockage and you would either do a stent or bypass surgery or whatever is appropriate at that point. But the more interesting case is when you don't find a major blockage in the coronary arteries, which low-risk women or intermediate-risk women have had compared to men. What do you do then? So there are usually 3 other diagnoses that women can have that cause chest pain much more than men have. One is coronary dissection. Rare, but still more in women.
And it is high mortality, right?
Yes, exactly. And it's usually in the peripartum period when they are pregnant or have given birth a few months ago. Within that time period, it seems like the hormonal change effects on the arteries or the heart's arteries walls make it thinner and more able to tear. Plus the changes that happen with all the fluids and everything.
And the blood pressure changes during pushing and postpartum kind of changes the hemodynamic
effects. Makes the arteries of the woman's heart prone to dissection or tear. So that could be something that the coronary angiogram doesn't necessarily pick up, but is causing the chest pain and is very dangerous. Another entity is called broken heart syndrome or Takotsubo cardiomyopathy, which is much more prevalent in the female population than in males. Usually happens with some surge of adrenaline, either with emotional or physical stress. Does happen in males, but much more often in females, where the heart's muscle balloons out. And when you do, and on the EKG, it looks like there's a full-blown heart attack with chest pain. And when you do the angiogram, all the arteries are clean. And then within a few days, you do an echo, you see the ballooned out left ventricle or muscle of the heart, and it's not pumping well, it's just doing this. And then in a few days, it completely reverses and is back to pumping fully.
So, as the name says, broken heart, I think there is some truth to the word that, yes, when there is emotional ups and downs, it does affect the way your smooth muscles in the heart is functioning. And over a period of time, hopefully it recovers.
Correct.
And it gets back to normal. It's amazing. So there is proof to what the poets have said. And as a cardiologist, I think it's great that you can kind of compare those things. So it's really nice and amazing to know that even though there might not be a blockage, there might be still a serious thing happening. So it's very important that you do get evaluation and a follow-up to make sure how your symptoms have done. Because if your symptoms have persisted in spite of negative workup, you should be followed up. As you said, there might be a coronary dissection happening, which is really high mortality cases.
Correct. And then the most important factor when a woman comes in with chest pain, all the tests look normal, an angiogram is done, and there's no blockage, is another entity called Syndrome X, or Cardiac Syndrome X, which is microvascular disease, which women have much more than men.
Correct.
And what that means is the small vessels of the heart that feed deep into the heart that an angiogram cannot pick up, a CAT scan can't pick up, an EKG cannot pick up. That's where the disease is and can constantly cause chest pain, especially when you exert yourself in any physical way.
Correct.
And women present with that more than men.
Correct. That's why Syndrome X.
Exactly. And that's why we can, there's a lot of medicines now, there are women's centers now that are specializing in treating this.
Correct. So it's amazing we've talked about this and we can talk about it again and again for a long time. We're going to take a short break and we'll be right back. Want water? You good?
I'll do a little water if it's okay, thanks.
Huh? Cold water, yeah.
Cold, please. Thanks. How much
So
more?
good, 17 minutes, so we're
17
fine.
minutes done already?
Yeah.
Good.
So we have
13
13
minutes
more minutes, yeah.
We'll talk a little bit more about
Cardiac evaluation.
testing and...
So then we'll just start with first basic cholesterol की क्या करना है? Cholesterol बताया कि EKG चालू कर दे.
EKG we'll talk about testing. I'm just wondering if there's anything more in women and heart disease. Is there anything more you want to talk about, like the Women's Health Initiative study from your perspective?
I'll avoid it because
it's beyond their scope.
Because WHI looks into both stroke and,
Yeah, it's fine.
So we'll leave it alone.
No, we can talk about...
EKG,
echo. You can ask me a little bit about after a heart attack, what is the difference between men and women? Sequela of a heart attack, and differences in men and women.
Oh, I should have put it, I asked about post-op. What was the difference in recovery?
So post-op, but you can ask about once a heart attack has officially been diagnosed,
is that the way
what happens, what's the sequela for men versus women, and there is a big difference.
Okay. Is there anything else then? Because we can do two things like
AFib and stroke, the CHADS-VASc score is actually very different. So there's that whole entity about AFib, which I don't know how prevalent it is in the Indian population, but...
No, we can talk about AFib, and talk more about that, like post-MI, AFib, or just in general.
AFib in general, because there's, the CHADS-2 score.
Right, so we can talk about that,
right.
yeah.
There's a CHADS-VASc score we can talk about.
Okay, we're ready.
2 more minutes left.
Yeah.
Good, thanks.
Welcome back to Dr. Gore Show. So today we're talking about heart disease in women and evaluation. So far we've discussed that women have a different presentation. The onset of heart disease is a little bit later. Their symptoms are sometimes ignored. They need to be evaluated if the pain persists, because even though it might not be myocardial infarction or MI or heart attack, there might be other causes of this chest pain. Now, say you've diagnosed this person with MI, and you give her the medications, the endothrombolytics and stuff, and you discharging a woman. Now, does a woman have a different prognosis or sequelae compared to a man who has the similar, say, blockage or MI, or in fact of the same area and same amount?
Correct. That's a great question, because women do seem to have a different prognosis and morbidity and mortality, we like to say, meaning quality of life and risk of death after a heart attack.
Okay.
If the same woman and the same man have the same exact heart attack in the same exact artery, and it is treated on an emergency basis, and then they're brought into the ICU and stabilized.
Correct.
In the next few days and few weeks, the woman is at much higher risk of developing heart failure as a consequence of that initial heart attack than the man is. And you have to be a little more aggressive with the medicines and the monitoring that you do after the heart attack.
Wow.
And then the other thing we were discussing off camera was atrial fibrillation, which is an arrhythmia of the heart, where out of the 4 chambers of the heart, the top 2 chambers are just doing this. Instead of beating in synchrony, just doing this.
Correct.
And I don't want to get into the details of the arrhythmia, but because the heart is just doing this, the blood doesn't flow.
Circulate.
And therefore it can sit there and clot.
Right.
And then what can happen is if there is a clot, it can go right up to the brain, causing a stroke.
Correct.
So for over a decade now, we have tried to determine which patient that has AFib, or atrial fibrillation, is at risk of stroke.
Sure.
They came out with a score called the CHAD score, which is, CHF, heart failure, high blood pressure, age, diabetes, and if you've had a stroke before, those things put you at risk. Over time, using that score for over a decade, they found that women, even if they had a low score, were still getting strokes, and they were massive strokes. So a new score came out after large research studies were done that was called CHADS VASC, and the S in that CHADS VASC is actually for sex or female sex.
Correct.
That gets you a point, which in this case is actually a bad thing.
Correct.
And increases your risk just on the basis of being a female, of having a stroke in AFib.
Correct. So, as we were discussing, fibrillation is when the top part of the heart is moving very, very fast. A lot of times, some people feel like their heart is beating fast, their pulse is fast. If they drink coffee or tea, or they have thyroid disease, it kind of precipitates things. So, a lot of times we find it either on an EKG for asymptomatic patient, or sometimes they have shortness of breath, they can't breathe because the heart is not pumping out enough blood, and we diagnose this either with the studies, which is like more of a conduction studies, and we find that these people have extra heartbeat going on. And that's why if you have fibrillation, as Dr. Kedar mentioned, you need to be treated, if you're a woman, in a slightly aggressive way, because the outcomes can be different and prognosis is different. So we've had this patient, now, we've done the cholesterol, the basic workup, going back to somebody in your office. Do you recommend doing EKG on a normal annual exam for somebody who's 40 and above? What are your recommendations for just asymptomatic patient coming for a routine annual checkup?
In general, once a patient comes to a cardiologist, there's nothing technically that you do as a part of a routine annual checkup.
Right.
In a general physician's office, from now onwards, it's been that an EKG is part of their annual physical exam. But beyond the EKG, which is a cheap and quick test, there are multiple tests that patients can get to help understand their risk of future heart disease and events like heart attack and stroke, or heart failure, or even AFib.
Correct.
An EKG is a very complicated thing, even though it takes a moment to get one, and we do it all the time. If I were to get 100 people out on the street to do EKGs, I'll get 100 different readings, and they might all be normal.
Correct.
So don't be afraid if your EKG has an abnormality according to the internist or primary doctor.
It depends on the axis. It depends on, female have a little bit, when you're pregnant, it looks different. You can have normal physiological inversion of the waves, etc. So, yes, so EKG is kind of like something which is a baseline testing you can do just to start off, but it doesn't mean if EKG is abnormal, there's some underlying cardiac issue, because there can be some physiological changes which can be manifested in terms of abnormal EKG. So after an EKG, what's usually, is it an echocardiogram to confirm your diagnosis, depending upon, if there's edema, shortness of breath, or you'll go ahead and do electrophysiological studies? Like, how do you work this patient up?
Right. In general, testing, like I said, is a little bit of a complicated thing because short of cutting open someone's chest and looking directly, and even then it's not perfect,
Correct.
we can't tell exactly what's going on with the
Right.
heart. And it's
But
not,
you're trying your best
Right.
to come up with a diagnosis here,
correct.
right?
So every test has an imperfect profile in terms of its accuracy. So if you choose it correctly, such as an EKG during chest pain,
Right.
or an echo when you're suspecting heart failure, or again,
Right.
when that heart is not pumping well, then the test's accuracy increases. So other tests besides EKG, like you asked, includes echo or echocardiogram, which is basically an ultrasound of the heart, kind of like we do for a fetal,
Correct.
for a pregnant lady.
Correct.
We just do it for the heart, and we see how the heart
The
is
function.
beating. Exactly. We see how the heart is beating and the function over there. We see all the 4 valves, how they open and whether they leak back or whether they're too narrowed and don't let blood flow forward. And we can look for major structural abnormalities like in congenital heart diseases,
Right.
for example. We can look for holes in the heart, which is technically called ventricular septal defects or atrial septal defects. The other test is, of course, everyone has heard of a stress test. And even within that, there are multiple modalities.
Absolutely. Somebody who can walk, cannot walk, and nuclear, all those different
Exactly.
kinds.
Exactly.
So your physician is the right person to decide which is the normal test
Yes.
that you can do. If you have ability to do running, they will do a traditional stress test. Otherwise, they can give medication to see if the heart, when it's pumping fast, and what happens to that. So we've done, say, the cholesterol testing, we've done the EKG, we've done the echocardiogram, they've done the stress test. Is there anything new to figure out the locations of those abnormal blood vessel or the blockage, if it is? Like, what about those CT with cardiac scores, and then they have different kind of MRI, that people are looking into different things without being invasive. How much information can we get?
Right. So again, for the past few years, there have been newer studies, most prominently CT angiogram and MRI of the heart, or cardiac MR, that try to better elucidate parts of the heart. The CT scan can almost replace a cardiac catheterization if it's done correctly.
Okay.
But there are major downsides. One, you're getting a lot of radiation.
Right.
2, if there is a blockage, you have to do a cardiac catheterization anyway. 3, you can still miss things because, again, every test is imperfect.
Correct.
The cardiac MRI is the most sensitive and specific depending on the situation.
Okay.
But again, you have to lie down in an MRI machine.
Right.
It's many hours. It's impractical. Not a lot of people know how to interpret it properly.
Because the heart is moving, and any moving object is going to give artifact for MRI.
Correct. Correct. And more importantly, women, just to go back to our initial topic, have a higher, what we call false positive rate
Correct.
of testing. Meaning, if they were to get an EKG while they're running on a treadmill, which is just a regular traditional stress test, no additional imaging, they are more likely, even if their heart is in reality normal, to have an EKG that looks abnormal. In that case, if that happens, you are forced to do further testing.
Right.
Which could be a catheterization,
Right.
which is the next test I was going to talk about, which is an invasive study where we puncture the arteries of the wrist or the leg and then take small, thin wires called catheters that go up the arteries of the leg or the wrist and around to the arteries of the heart. At that point, we inject a dye, which if there's an allergic reaction to can be very problematic, even fatal. But the dye can go down the heart's arteries, and with an X-ray machine, we can see how the dye flows through the arteries. If there's a blockage, we can
You will
stent it
pinpoint it.
open.
Correct.
Exactly. But like I said, with women, there are oftentimes abnormalities on the EKG during a stress test which are falsely positive, meaning falsely abnormal, so the angiogram will be normal.
Correct.
So in reality, if you're not choosing the correct testing and you jump to that conclusion, you can subject a female patient
Unnecessary.
to unnecessary invasive testing.
Correct.
But in general, the idea, if testing is needed,
Correct.
to do a non-invasive test first and invasive next.
Absolutely. So thank you so much for coming and to talk about this very sensitive topic, and especially for OBGYN. I think we stress so much about making sure that the transition from perimenopause to menopause and the health continues. So I think we learned a lot today. I think the take-home message is don't ignore your symptoms, control your cholesterol. If you don't feel good, please go to your medical doctor and cardiologist and get it evaluated. They will be the right person to decide which test is right for you, because if your husband got angiogram doesn't mean that you should get that. I think there is a difference in evaluation. And as we just spoke, there are more and more non-invasive modalities which can diagnose without putting, invasive testing of catheter and dye. Till next time, good night.